Okay, welcome to Chapter 7, Prenatal Care. What is the purpose of prenatal care? Well, our main purpose of prenatal care is to have a healthy baby. So that's what we're going to look at. So the goal of our early prenatal care is just to have a healthy baby, make sure we can develop some strategies and things to help mom promote good health, good hygiene, good nutrition, intervene if we need to, prevent any complications that might occur throughout her pregnancy. We're going to make sure we're checking baby, we're checking mama, we're checking all of those things. We have two human beings instead of just one right now. So we got to make sure our goal is to take care of both people the best that we can. So as far as your role, if you work in an OB office, you're going to be screening those moms, you're going to be monitoring their vital signs, you're going to provide lots and lots of education, collect lots of data, answer lots of questions, order tests, all of those kinds of things for these moms. So first prenatal visit's going to be very, very long. Sometimes these moms are actually there an hour, hour and a half trying to get everything accomplished. That's where we're going to draw baseline labs. We're going to identify any risk factors. We're going to confirm that they're pregnant. We're going to make sure we know their due dates. We're going to talk to them about all their history. We're going to see how many times they've been pregnant, how many times if they've had another baby. So as far as I want you to really become familiar with these terms because that's going to be really important. Gravida means pregnant. So how many times have you been pregnant? If you're a nulli gravida, you've never been pregnant. So that's gravida. Nulli gravida would be first pregnancy. So gravida just means the number of pregnancies you've had. So nulli gravida would be our first pregnancy. Multi-gravida would be more than one pregnancy. Parity, or the P, is the number of pregnancies past the age of viability. The age of viability is 20 weeks. So parity, gravida, para. Gravida, how many times have you been pregnant? Parity is how many babies have you delivered past 20 weeks. Prima para, that means they're delivered for the first time. Multipara, delivered more than the first time. So always gravida means pregnant, para means to deliver. So thinking about that, you will need to know this system. It's called the GT-PAL system. G stands for gravida. T stands for term. P stands for preterm, any baby after 20 weeks, but before the end of 37 weeks. That's considered preterm. Even if the baby is deceased, that's still considered preterm after that 20 weeks. Abortion, any pregnancy that ended before 20 weeks. This can be miscarriages, this can be elective, whatever, but abortions, number of pregnancies that ended before 20 weeks. And then living, number of children delivered who are alive when the history was taken. So think about that. If you've got a mom that comes in and she's pregnant for the first time, let's see you have a mom that comes in and she's pregnant now. She has a 3-year-old at home that was born term. So she's got that one. And then she had a miscarriage at 8 weeks 10 years ago. That's 3. So she's a gravida 3, para 2, because she had 2, and term, she had 1. So she's had 1 abortion. But she's a gravida 3 because she was pregnant 3 times. Even though she didn't have that 1, it was an abortion. It was an A. She did have a number of pregnancies that ended at term. She had a gravida 3, and she had 1 term at home. And then kind of keep that system in your head because you will need to know that. So if you have a mom, gravida, term, preterm, abortion, living, and if multiples just means that they've had twins. So if we have a mom that comes in, let's say we got Katie. Katie's a gravida 3, term 1, preterm 0, abortion 1, living 1. So she's pregnant right now. She has a term baby. She had an abortion or had a miscarriage, and she has 1 living. So she's a gravida 3 because she's been pregnant 3 times. So know that system. So we're going to look at all these risk factors. I'm not going to read these to you, but we're going to look at their surgical history, their family history, their social history. What did they do? What have they done? What are they currently doing? What are their hobbies? Anything that could tell us a significant risk to that baby. We need to know that. Do they have all their immunizations? Have they had any genetic testing? Has anyone in their family ever had a genetic abnormality? We need to know those things to help with this pregnancy. They're going to get a complete physical, head to toe. They're going to do a cervical exam. They're going to look for that Chadwick sign. They're going to look for all of that stuff. They're going to do a complete lab work. They're going to screen for everything in the beginning, probably even more than I have listed here. This is where we need to know, what is mom's blood type? Is she Rh positive, Rh negative? What is her blood type? Is it A, B, O, AB? What is her blood type? So all this stuff is going to become very, very important to know. What is her rubella status? What has she got going on? Does she have any history of anything? Does she have any STIs? Anything like that, because all those are going to come to play when it comes time for delivery. So how do we know when mom's going to be due? We have this thing, Bing, we have this, sorry, that was my dog. We have this thing called estimated due date. It's the estimated date of delivery. When is that mom going to deliver? The old term that we used to use was estimated date of confinement. We use this thing called Nagel's Rule. You will need to know it. Nagel's Rule says you take the date of their first day of their last menstrual period. So let's just use an easy one. Let's use last day of their first menstrual period was May 1st. So May 1st was the first day, sorry, not the last day of their menstrual period. The first day of their menstrual period was May 1st. We're going to subtract 3 months, then we're going to add 7 days. So May 1st, April 1st, March 1st, February 1st, add 7 days, February 7th would be her due date. So it's first day, last menstrual period, subtract 3 months, add 7 days. Very rudimentary in getting an estimated due date, but that's kind of how we come up with them. We're going to look at her uterine size. How big is her uterus? Landmarks for pregnancy. Is she feeling anything? Quickening just means the first time that they feel movement. We usually don't feel, she probably isn't going to feel this yet until about, if she's a multigravida, sometimes they can feel it earlier, around 16 weeks. But if you're a prima gravida, they don't really know what they're feeling. And so it may be more closer to 20 weeks. A lot of times these moms will get an ultrasound, especially, if they, had anything that they feel like might be wrong. They will do an ultrasound to make sure everything's okay with baby. Then we're going to do, that risk assessment. We're going to take all of that stuff. We're going to take their history. We're going to take their physical exam. We're going to take all their lab tests, and we're going to kind of determine what the risk is for that mom and that baby. Now, if mom has had a difficult pregnancy before, or mom had pregnancy complications before, usually this may come into play the second time. So she may have more things that are going to go wrong the second time. If mom's mom had difficulties, that's something that we have to know. If mom's mom, maybe they didn't test her mom or anybody for preeclampsia, but she said, yeah, after I delivered, I had all kinds of complications, or, baby was 10 pounds, she had gestational diabetes, anything like that is going to could complicate this pregnancy and subsequent pregnancies after that. We want to look at their social things. What kind of living conditions do they have? What kind of food is available for them? Where do they live? Do they live in a part of town where there's a lot of exposure to tetragens? Is there domestic violence involved? Do they smoke tobacco? Or do they use illicit drugs? Anything like that. And then we're going to take in consideration their age. If they're a young adolescent, that's going to put them at higher risk. If they're a mom over 35, we consider that a geriatric pregnancy. And there's more risk factors with that. So we're going to take all those kinds of things into consideration when we're coming with that risk assessment. What is this risk for this pregnancy? So the rest of the prenatal visits are going to get a lot shorter. So you're going to come in, they're going to look at certain things. So every time you come in, they're going to look at your weight. They're going to look at your blood pressure. They're going to check your urine for protein. They're going to check your urine for any infections. They're going to look for glucose. They're going to take a fetal heart rate. They're going to look at fundal height. They're going to ask you if you're having any questions. So as far as prenatal visits, you're going to go once a month from weeks 1 to 32. So week 1 to 32, it's going to be once a month. Every other week between week 32 and 36. So every other week, because we know that more complications are going to start coming that last few weeks of pregnancy. And then every week after 36 weeks. So every week after 36 weeks, you're going to go. So we're going to see them a lot. And we're going to talk to them about danger signs. You know, what do you need to report to us if something happens? So that first trimester, very first trimester, that 1 to 3 months, we're going to start talking to them. These are the danger signs that we want you to report. Burning on urination. If mom gets a urinary tract infection, it can increase our chance of miscarriage, increase our chance for premature labor. Severe vomiting. And I don't mean just a little bit of nausea and, oh, I threw up the other day. No, this is severe vomiting. This is where we get into the hyperemesis gravidarum. We'll talk about that. Diarrhea can mean infection, dehydration, more problems with fetus, preterm labor, fever and chills. We do not want mom's temperature to get over, usually they say we do not want mom's temperature to get over 100.5. So we want to keep that temperature down. Sometimes the doctor will prescribe acetaminophen and tell her she can take some Tylenol if her temperature gets up. But we need to know about that because that can cause some problems with the fetus. Any abdominal cramping, any vaginal delivery, any vaginal bleeding, especially these first trimester. If you get a mom that comes in and she's just found out she's pregnant, a week later she comes in complaining of severe right lower quadrant pain, I would be thinking ectopic pregnancy. You know, what's going on with this mom? Any bleeding? You know, what other symptoms are you having? And be checking mom for that. Sometimes those are danger signs. Now, subsequent things, a couple of things that some of the times the doctors will ask, we're going to do some subsequent looking at for screening. Sometimes we will ask them to do a screening test. It's called maternal serum alpha feta proteins. What this shows, we usually do it between 15 to 20 weeks. This will tell us chromosome abnormalities and it will tell us if baby has neurotube defect. It will not really tell us anything else, but it will tell us those two things. And it's maternal serum alpha feta protein. So it's just a quick blood test for mom and we can get that and it kind of just helped us predict the future. Some moms refuse it because they say they're not going to do anything different if it does come back positive. We will test and screen every mom for gestational diabetes between 24 and 28 weeks. They will have to go in and get a glucose screening test, and we'll talk about that. If mom is RhoGAM negative, so if mom is Rh factor negative, we need to screen her for antibodies. That means, does mom have antibodies inside her body that could be attacking that baby? So we will look for those. And that's a big deal to help prevent any problems with baby later on. We're going to screen mom for group B streptococcus. It's very common for moms to have that in the vaginal tract. So we're going to screen for that because that can get up into baby and cause lots of problems for baby. Then we can do a DNA blood test, and that we would do for moms who are high risk for Down syndrome. So this is kind of optional. This is optional. These right here will be required. We have to know if mom has gestational diabetes. We need to know what mom's blood factor is, and we need to screen for that group B strep. The other ones are screenings, and all of these are screenings. They're not diagnostic, they're just screenings. Now, once we get the diagnosis, we do further testing. So how do we test? How do we know a baby's doing okay? How do we know our baby's doing okay inside there? Because we can't see them, we can't feel them, we can't touch them. So how do we know? So one, we can do kick counts. We basically just tell mom to keep a record of how many times that she feels the baby kick. So we tell mom do it at the same time each day. You should get 10 kicks in a day. Most moms, especially if the babies are early, if you're only like 20 weeks, you might not feel those kicks because baby's not real strong yet. But as the pregnancy progresses, you should feel fetal kick counts. You might get 10 kick counts in, 15 minutes. So we want you to get at least 10 kick counts, 2 hours to get 10 kick counts. As long as you're getting that, we're doing okay. If you do not get that, we would request that mom give us a call and we can take a better look at it. So kick counts is a very non-invasive way of looking at our babies. If the baby's not doing well, we're going to go to more invasive things. And this isn't really invasive, but we're going to do more things to look at the baby. So one, we're going to do ultrasound. And we're going to take a look at the baby. We're going to look at their heart. We're going to look at their structures. We're going to look at their neurological status. We're going to look at all of that kind of stuff to see. So an ultrasound is going to give us a much better idea of how well nutrients are getting back and forth to baby. It's going to look at our placenta. It's going to look at the blood flow from the placenta. It's going to look at the fetus. It's going to look at the kidneys. It's going to look at the heart. It's going to look at all the things that are keeping that baby alive. Now, if it's early, if you are like 12 weeks, sometimes we have to do a transvaginal ultrasound. So they have to go up vaginally and look at it. If you're further along, we usually can do it transabdominal. If we're doing it transabdominal, mom has to drink a lot of water before she gets there, and she's gonna have to hold that water in because we want that bladder to be full, so it pushes that uterus up so we can see that in that abdominal cavity. The other thing we can do, which we've already talked about, is the maternal serum fetal alpha protein. Again, we recommend that between those things. If it's elevated, we're looking for fetal spinal defects. So that would be like spina bifida, myelomeningocele, things like that. If they're low, we're looking for Down syndrome. So some moms will want this and some moms do not. So, and the weeks on this is going to vary depending on what book that you look at, but usually it's between 15 to 20 weeks, somewhere in between that level. Other things that we can do that are much, much more invasive. So if we got a mom that has a history of something, or maybe she has a family history of something that's going on, that she really wants to know what's going on with her baby, or she's wanting to make decisions on what to do about her pregnancy, she can do an amniocentesis. Now, a couple things that we do for amniocentesis. It's where we actually go in through the abdomen and we withdraw amniotic fluid. We look at the chromosomes, we analyze those chromosomes. This is done between 15 and 20 weeks. We do not do it before 15 to 20 weeks because there's not enough fluid, for one, and the baby's not up into the abdominal cavity very well. The other thing that we look at with an amniocentesis is lung maturity. So we go in, we take a little piece of that fluid, and we analyze that fluid for leptin and spiromyelin, and that tells us how mature the lungs are. So that's the only way to really look at lung maturity is through that amniocentesis. Alpha fetoproteins, these are not maternal anymore. These are alpha fetoproteins. These are actually from the baby. If they're elevated, we're looking for that neurotube defect. We're looking for a multi-pregnancy. If they're low, we're looking for chromosome abnormalities. So again, these are not maternal. That's alpha fetoproteins, and we're looking directly at baby. Now, let's say we have a mom that comes in and she's 10 weeks pregnant, and maybe she's in her, 40s. Maybe she's 41, 42, first pregnancy, and she's like, I'm really scared there's something wrong with my baby, and I want to make sure that everything is okay because who's going to take care of this baby when I get old and I can't take care of it because I'm older. I'm an older mom. So this is usually done between 10 to 12 weeks. So it's early in the pregnancy. We actually take a piece of placental tissue. So this is not an amniocentesis. We're taking fluid. This is where we're taking tissue. We aspirate that through a catheter and we go examine it. We go through the cervix to do this. So we go actually through the cervix, ultrasound guided, to go in there and do it. It can be done transabdominally, but usually it's done through the cervix. So know the difference between those two. Another thing that we can do is what we call percutaneous umbilical blood sampling. This is similar to an amniocentesis. However, it's fetal blood is withdrawn from the umbilical cord, not amniotic fluid. So actually we're doing like a blood test on the baby, not amniotic fluid. Now, one thing that we can do, another thing that we can do that's pretty non-invasive and it doesn't really hurt anything, is a non-stress test. So kind of put that in your mind, a non-stress test. This is we're going to monitor the fetal heart rate. This is your fetal heart rate here, and we're going to look at acceleration patterns. So this means that every time baby kicks, we get a little elevation in their heart rate. Baby kick, elevation in the heart rate. That's called a reactive non-stress test. That's reassuring. We want that to happen. So non-stress test, we want reactive. And so because we haven't stressed the baby in any way. We're just hooking the mom up. We've got the tocos on her belly. We got the fetal heart thing on there. And when baby kicks, heart rate goes up. That's good. That's what we want to see because baby's active. When baby's active, heart rate goes up. We're good. So that is your non-stress test. Now we're going to do a contraction test. Now we're going to stress the baby. So what we're going to do is we want to see how well that baby handles contractions. So we need 3 contractions within a 20-minute period. Now, we can make these happen by doing nipple stimulation, because actually stimulating your nipples will cause oxytocin to be released from the brain and cause contractions of the uterus. Or we can use oxytocin, and we can give them a little bit of oxytocin, which will make them have some contractions. Now, a negative contraction test is what we want to happen. That means there's no decelerations during the test. Now, decelerations, that means a baby's heart rate is going down. We don't want to see that. We want to see their heart rate going up. So if they have a deceleration with half or more of the contractions, this is a positive test. And that means we have a positive contraction test, and we don't want that. We want a negative contraction test. Okay? So this is the one time you don't want positive. You want negative. Your contraction test should be negative. So biophysical profile. Biophysical profile, this kind of combines the non-stress test, and it looks at ultrasound measurements. It looks at the baby's breathing. It looks at the baby's movement. It looks at the baby's tone. It looks at the baby's amniotic fluid. So when we look at all of this, I'm not going to go into a ton of detail, but I just want you to think about biophysical profile. See your B here, it looks like an 8. You want a score of 8 to 10. So your biophysical looks like an 8. So you got 8 to 10. You got good fetal well-being. So my biophysical profile of 8, looking good. So because what we're doing here, I think there's like 5 things that we're doing. Each are scored 0 to 2. So 2 being the best. If all 5 areas are a 2, you've got a 10. So think about the lower your score, the more complications that you're going to have for your baby. So if you got a mom that comes in and she's scoring a 2, we've got a problem with our baby, and mom's probably going to have an immediate C-section to figure out what's going on with that baby. So that's a biophysical profile. Now, let's talk about some common discomforts. Some things that moms are going to have when they're pregnant. Just because you're pregnant, you're going to have this stuff. So first one, bleeding gums. Not uncommon for that to happen, especially during that, that beginning, because we have that increased blood volume. So we got a lot more blood. The hormones causes our tissues to kind of become a little bit more friable. So we're going to have some bleeding gums, nasal stuffiness, epistaxis, because we got all that increased blood volume. Morning sickness. Morning sickness is not uncommon. It's extremely common. So a lot of moms will have nausea. They won't feel good. They just can't eat certain foods, or they'll crave certain foods. That does not, because they have a little bit of nausea and vomiting, does not mean they have hyperemesis gravidarum. I will tell you what the difference is pretty soon. They might feel a little bit faint. They have increased urination, increased vaginal discharge, shortness of breath, breast tenderness. All of this is because of all that input of all of those things that are happening inside the body. Remember those physiological things that we talked about earlier? These are causing these things to occur. Okay, other things, heartburn. Now, heartburn is very, very common in pregnancy. Now, epigastric pain and heartburn are different. So heartburn is very common in pregnancy, but if you get a mom that is complaining of epigastric pain, that could be more of a problem. But heartburn is normal. Backaches are normal. Round ligament pain normal. Leg cramps, constipation, trouble, they can't sleep because they're uncomfortable. Fatigue, varicose veins, ankle edema. Now here again, edema in the feet is going to be common because of that increased blood volume. If you got a mom that has facial edema or edema in their hands, those are red flags. I would star those. Those are going to be more important later on. So what are we going to tell about mom? How to take care of herself through this pregnancy. So these are just some education things that we want to talk to mom about through her pregnancy. So keep her diet good. Make sure she's going to the dentist. Hygiene, she is going to have more vaginal secretion, so she's going to have more perspiration. There might be more odor. So have her, make sure that she's showering frequently. She might even have to wear a light day pad, something like that. Make sure you start advising her during that third trimester. Don't be climbing on things. Don't be doing anything where there could be a fall because your balance is going to be off. Breast care, they need to always be wearing a good supporting bra. When the milk starts to come in and their breasts are getting bigger and tender, it's going to feel a lot better if they have a good bra on. Sexual activity, there are no limitations. So unless there's bleeding or the doctor has put them on pelvic rest, there is no limitations for that. Employment, the only thing that we really tell them for employment is just avoid sitting for long periods of time. If you are at a sedentary desk job, make sure once an hour you get up and at least walk around the desk, pump your feet at the bottom. If you can put your feet up, do that. As far as travel, we tell you that you can travel. It depends on your doctor, what he's going to tell you about travel. But if you travel, make sure you bring all your OB records with you so that you have your records with you just in case something should occur. Always, always, always wear your seatbelt. Wear your seatbelt correctly. You have to wear your belt that comes across the top, and the lap belt has to go under the belly. If you're ever involved in any vehicle accident, no matter how small, you have to be evaluated in the emergency room. So just keep that. That's something that we need to let our moms know. Now, moms are not allowed to get any live viruses during pregnancy. So no live viruses. That means no MMR and no chickenpox vaccine. That is your varicella. Those are live viruses. So when you get those actually give you a small dose of a live virus. So we do not give those. If your mom is rubella non-immune, that means she does not have immunity to rubella, we will give her rubella right after delivery. So as soon as she delivers, right before she goes home, she will get her rubella vaccine. It is imperative that moms do get that rubella vaccine. If they would get rubella throughout their pregnancy, it will cause complications. They should not get the Marisol in any of their vaccines. I think pretty much most vaccines now are the Marisol free. We do not want her getting pregnant for that first month after she gets the MMR because of those complications. So mom can get influenza. She can get her DTaP. I'm pretty sure she can get the COVID because that's a non-live vaccine. So all of those are vaccines that they can get. We want them to get their influenza. We want to make sure that they've got their tetanus, diphtheria, and acellular pertussis. So those things are all good when they're pregnant. Medications, basically medications, we take none. No over-the-counter, no herbal, no home remedy, no nothing unless your physician tells you that you can take it. So those are just some things. Now, a lot of your doctors will tell you if you are uncomfortable, you can take some Tylenol. So those are just, Tylenol's pretty benign. So they will tell you you can take that, but do not take anything, and tell your moms do not take anything unless they speak with their physician first. Other things, no alcohol, no smoking. You know, they can, that second and third trimester, they can increase their caloric intake up to about 300. Folic acid, increase 400 micrograms a day. Do not diet during pregnancy. We hear a lot of young women coming in, well, I don't want to get fat, so I'm dieting. Do not diet during pregnancy. That is not the time to diet. So make sure that they're eating a good, balanced diet. Don't handle any raw meat or cat litter. Cat litter, they can get toxoplasmosis, so do not handle cat litter. If you have to handle cat litter, you have to make sure that you wear gloves. Make sure you wear gloves when you do it. Handle your cold cuts very carefully, your meat. Wear gloves. If they have gloves, they can handle the raw meat with gloves. And then just make sure they wash their hands really well. Avoid douching. Douching used to be very popular back many, many years ago, where they felt like if they had a vaginal odor, they would take some douche liquid and clean that vaginal canal out. We tell them not to do that. We tell you not to do that even if you're not pregnant, just because it changes the acidity of the vaginal canal and make it more susceptible to infection. The vaginal canal is self-cleaning. It should not need to have any douching. Do not use any hot tubs or saunas. So no hot tubs. We do not want their temperature getting over 101, so no hot tub use. Saunas are the same way. We don't want you to get any saunas, anything like that. As far as, I think we'll get to some of the other things. Let's see if I do. No strenuous sporting activity. So if you are, no competitive sports, let's say that. Sedentary bicycle, walking on a treadmill, running. If you've always done running, don't decide to take up a running at 3 months pregnant. But exercise is good for you. We want you to exercise, at least 30 minutes a day, but we don't want you to do anything competitive where you could have damage to the baby or something could happen to the baby. So just avoid anything that is competitive sports. Things to avoid, obviously we want to avoid all of these kinds of things, because what mom gets, baby gets. So if mom is smoking, baby's smoking. If mom is taking caffeine, baby's smoking caffeine. If I need to put meth on here because we had a big run of meth in the last few weeks. Any illegal substances. If mom gets it, baby gets it. Baby will withdraw from these too. So how do you prepare for birth and parenthood? Make sure that mom has got everything packed. She's got everything ready to go. She's got her delivery plan. She's maybe done her baby care classes. I would highly, highly encourage moms to take breastfeeding classes, because most of the time their milk has not come in when they're in the hospital. They go home, their milk comes in, and they don't have anybody to talk to. So I would make sure I get that. Siblings classes, if you've got little ones that you're not, you're concerned about how they're going to do with the baby, get them into some classes. Childbirth classes, they are very helpful in helping the moms know what is to come. A lot of moms think that they can handle some of the pain, they can handle everything, but without having the knowledge and having those classes and knowing what to do when the pain gets really great, those are very important to have those moms do. Danger signs. So these are danger signs in our first trimester. We've already talked about these in the last chapter. Just make sure that you're aware of those kinds of things. Now, we have not talked about these. These are danger signs in the second and third trimester. So any fluid gush that comes out before 37 weeks needs to be verified at the doctor. Is it amniotic fluid or is it just urine? So we need to know about that. Any vaginal bleeding has to be assessed by your doctor. Any abdominal pain needs to be assessed by the doctor. Any change in kick counts, any change in fetal movement, anything like that needs to be reported. Persistent vomiting. This isn't just your nausea. This is your persistent vomiting. Any severe headache that is unusual for the mom. It's not just a little dull headache that, I get these every now and then, and they usually go away. This is persistent headache. This can be a sign of your gestational hypertension. Elevated temperature, anything over 100.5. Any difficulty, frequency, urgency in urination needs to be reported. Blurred vision, they're seeing floaters, anything like that. Edema of the face and the hands, big one on these. Epigastric pain. That is not your heartburn. This is epigastric pain. Flush, dry skin, rapid bleeding, rapid breathing, anything like that. Increased thirst, increased urination could tell us that maybe they're developing some type of gestational diabetes. If mom is a diabetic and she's got, pale, irritability, lightheadedness, always make sure we're looking for those hypoglycemic events, because our moms that are pregnant will still get those hypoglycemic events, especially if they're taking insulin. So always do your nursing process. Always look at what we need to do first. And that is the end of our chapter.